Okay, great. Number one, I want to thank all of you for attending this. And basically, again, my name is Dr. BK Edmond, and Mel basically gave me the opportunity to speak with your group in February, and I feel like that was like 2 or 3 years ago because the information and the data surrounding maternal health in America and Black maternal health has been really kind of growing very quickly. Just so I'm on point. I have no conflicts of interest. I consider myself a husband, father, brother, anesthesiologist, and author, philanthropist, and most of all, a child of God. So, it's okay to that since we're in this group and it's a church organization, I'm gonna ask each one of you to bow your heads with me, and I'll say a quick prayer before we move forward. Heavenly Father, please continue to watch over us and our team in this effort. You've heard this prayer thousands of times before, but we ask only, Lord, that you give us crystal clear thought processes so that we might use the knowledge that we've developed in order to educate your people. Help us to have a silver tongue, Lord, so that I might speak in a way that's acceptable to you, and so that it might be received in a favorable manner. But most of all, Lord, help us to have a heart of gold. Help me to have a heart of gold so that no man may question my honorable intentions. These things we ask in thy precious name. Amen. All right, let's get rolling. This is my sister, Sandy. She is kind of like my partner on this. She's the person who got me into literature and taught me how to read. This is my other team, the Dream House team. All of these people are based in Atlanta. And this is a short story that I wrote called The Quilt Makers. And basically, it's a short story that's designed to educate our community on the high incidence of death of Black women. And what we try to do is use a concept that's called using art to heal. Today, my overall goal, number one, is to advance your understanding, but more importantly, I want to position you for action. And for those of you who are either on or can't attend, you're welcome to take the content of this talk and use it in any form or fashion in order to motivate and educate people around you in your network. One of the things I know we've been hearing, and we're focusing on Black maternal health care, but the real concept that we're trying to that we need to take home is the concept of reproductive rights. And a lot of us just assume that in America, a developed country, and in the world, a woman has the right to have a child. Well, the reality is that as we started to, as America started to deal with the crisis in maternal health care, they actually had to they put it under the umbrella of rights. Just like you have civil rights, you have reproductive rights. And that simply says that every woman should have the ability to have a safe, uh, respectful, accessible, available care, and culturally acceptable care and quality care when it comes to them having a child. But it doesn't just talk about them having a child. The key is it should cover all phases of care for the mother. That's before the mother becomes pregnant, her health at that point, once the mother becomes pregnant in the antepartum period, during the delivery, during the intrapartum, and during the postpartum care. So in all four phases of care for the mother in America, they should have access to quality rights. And there should be almost some standards that should be in place. Unfortunately, that has not been the case. And as a result, you've probably been inundated with different personal stories of mothers or friends who either lost their life or nearly lost their life. And these are healthy women that are coming in that do their prenatal care, and they're coming in and they're losing their life. We have doctors, we have Olympians. Serena Williams almost passed away when she was having a child. She had a pulmonary embolism, which is one of the complications or risk factors during pregnancy. And the reality is that that we keep hearing about these things, and we kept hearing about these things, but no one really took the time to make a coordinated effort in order to address it until about 2017, 2018, when some data came out from the World Health Organization, which basically showed that America, for all the fact that we're industrialized, in America, we have a very, very high incidence of maternal death. And then when they started looking closer at Black women and Indian women and Native women, American women, the incidence was even higher. So there's some tools that I've given to Brenda. We'll forward them to you. One is our organization created a Black Maternal Health Survey. You're welcome to take it and share it with your friends. But we also have, and I have an audiobook, a free audiobook link for you, where I'll share some of the reading of the book with you. And then I also have a PDF audiobook companion that I forwarded to them earlier. Our learning objectives for today. Number one, we're going to basically, I'm going to give you some elevator numbers that some numbers you can take with you when you give an elevator talk about the issue. We're going to discuss the causes. Then I'm going to introduce you to what we call a mother's health support network. In other words, I'm going to show you where this is, where people are doing well in terms of maternal health and what they have in place. But there's good news. And the good news, quite frankly, is that since 2018, our government has begun taking this thing seriously. And for one, the Surgeon General basically issued a call to action and had started a number of projects going on. But more importantly, we had a sister girl who was our vice president. And one of the first things she did was get with some other African-American women leaders and develop and push forward a program that's called the Blueprint, the White House Blueprint on Maternal Health. That's basically really, and that is the good news. And I know we've had another election, and everybody wants to say that things are kind of tough and are going to be terrible. But in this situation, the first thing take home message I wanted to give you is that the problem that we're talking about, and this is one thing I've learned over the past like 9 months giving this talk and doing research, the problem we're talking about has already been solved in numerous places in the world. So while we're running around, so a lot of times in the African-American community, we run into issues that are hard fixes. But the key is they're hard fixes, but you almost like just assume they're going to chronically be there. And then when you look across the world for African Americans, the issue's there and it's chronically there. Well, that's actually not the case with maternal health. There are places you can go in maternal health where if you, and this is not just for Black women, this is for, you can go to a country over in Europe and and they've taken the issues where they have 90% less incidence of having problems. So they have already put programming and things in place to address this issue. It's just that America just hasn't been there. But good news, let's talk about some uplifting news. Number one, you had that blueprint, the White House blueprint. And basically what they did, some of the things that they've done in the past 2 years, they've actually established protocols. So anytime a woman or a mother goes to the hospital for anything, they automatically get put into an algorithm for care. So instead of having a person come in and show up and get a blood pressure or get vital signs that and the individual clinician has to make the decision on what to do, they have built-in mechanisms in the system. So if you go to Hopkins and you've been pregnant within the past 6 weeks or 8 months or whatever, when you hit the door, the fact that you've been pregnant means that you're treated in a different way and you go towards a faster algorithm. If you've been pregnant within the past number of months, within 45 minutes, someone from the OBGYN department lays a hand on you to do a physical exam. So these emergency protocols were put there. But what's more important, for all the hospitals in America, they made it set, just like we have to do certain standards for cardiac life support, and we have to have a cart that has a defibrillator on it. Well, hospitals now have to have a maternal resuscitation cart. So basically, in every standing hospital, you have to have a way to emergently give medicines and have the equipment readily available to treat mothers who are having problems. What's more important, if your hospital doesn't deal with a lot of pregnant women, then you're required to have a way to stabilize that patient so that you can transport them to a hospital that has it. That's one of the things that happened. Medicaid used to cut off for 2 months for mothers. Now they've extended that Medicaid to 12 months, where Medicaid will cover the mother for 12 months instead of 2 months. And what we know now is that a maternal death is considered any death that occurs to a mother 12 months after delivering. The other thing they did was create a birthing friendly label. The birthing friendly labels basically is a hospital that's bought into the federal government's program. So when your mothers are looking around or people in your church are looking around where to deliver, check and see if they got hospitals that have the healthy living, the birthing friendly label. Every hospital doesn't have that, but these birthing friendly labels have bought into all of the safety measures that the federal government wants to have. The other thing, there's a new hotline they created, and this is the number for the hotline. I won't stay on it long, but the reality is there's a 24/7 hotline for any mother who's depressed, or if you have a mother who's thinking suicidal or has mental health issues, that will tie you directly into regional support systems for the mothers. I'll sneak down. They've done other things in terms of ensuring the Medicaid issue, but one of the things at the bottom is they're diversifying the prenatal workforce. One of the problems is we have maternal deserts where there aren't enough workers to work in those spaces. Well, the bottom line is right now they're bringing in more doulas, more nurses who can teach mothers how to suckle. They've thrown money behind training up a group of people to help mothers learn how to better take care of their child. The other thing is for veterans. You remember we were at war for almost 18 years. There are a number of women's veterans. One of the things that Kamala Harris did, was she went into the Veterans Association and made it so that the VAs actually have the ability to support mothers for 12 months during the postpartum period. So even if a person, so one of the things you have to take into consideration, and you might think in the back of your mind, is some people have benefits that they won't be using. So if you have a church member who's pregnant, let's remind them about their VA benefits. Or if they're married to a person and if they're married, sometimes the wives of soldiers get VA benefits and stuff. And if they do, and if they get pregnant, they can get resources for 12 months from the VA. The workforce shortages, they're doing more things to get more OBGYNs and midwife patients. But the other thing that I bought into is there's a Hear Her campaign. And there's a national campaign that's designed to basically teach the support systems. That's the cousins, the husbands, the people that are around that pregnant woman, to teach them to recognize the signs of a mother in distress. And it's called the Hear Her campaign, established by the CDC. There are a number of symptoms. I'll roll through them later. Most of them deal with blood pressure issues, breathing issues, and blood pressure issues and bleeding issues are two of the top major issues that they deal with. But they teach the common person to recognize those signs. Okay. The other thing that they did that was critical was they basically passed this bill in May 2023. And what the bill did was create state committees that basically review every single death that occurs in a state. So basically, the funding for these committees comes from the federal government, but the state is the one who administers them stuff. So basically, they put money before, like about 2018. A lot of the establishing of these review boards for maternal deaths, it was kind of like voluntary. They give you some money, but they didn't give you enough money to make it really functional. Well, when Kamala and her team came in there, they basically financed it up to about $118 million and made sure that now we're at a point where all 52 states have standing committees with doctors, nurses, so that if a person dies, or if a mother dies of surrounding pregnancy, they can find out why. Now, it's 2024. The reality is, if you asked about the data or the information to even make a good decision on what's good or what's bad for mothers, if you go back to 2020, they really didn't have a means to gather quality data and stuff. And so that's one of why it's so important for these committees to be established. Now, in the state of Georgia, the committee basically the Secretary of Health, who, remember, it's federally funded, but it's run by the state. The Georgia Secretary of Health fired everybody in the maternal review committee because some of the information on some cases they were reviewing got released prematurely. Now, the key is they because these committees really haven't been running for more than about a year and a half or 2 years, in some situations, they're still trying to figure out exactly how they're going to handle discussions and information. Most of the cases they review are at least 2 years old. So you're not going to run into a committee doing any type of review. If a woman dies, the results of the reviews usually are at least 2 years down the line. So the bottom line is these aren't developed for malpractice use, and they're not developed for political use. The information is being gathered because they really don't know how broad, how wide this problem is. So we'll keep it moving, and basically, but that'll tie us into our first teaching question. And that teaching question is a true or false question. The question is, maternal mortality review committees are financed by the states and controlled by the states. True or false? And of course, based on what I just said and everything, we know that's false. Financed by the federal government, controlled by the state. And all you got to do is go to the Atlanta Journal-Constitution and find out how much leverage the Secretary of Health have on the state level and stuff. So, but the reason we want you to look towards the Maternal Mortality Review Committee is because it gives you information specific to your region and to your area of the country. Here's the second teaching question, okay? We listed some of the things on the White House blueprint. Which one of the following was not part of the White House blueprint for addressing the maternal health crisis? Number one, creating health and safety requirements for maternal emergencies in hospitals. We mentioned that already, that every hospital now is supposed to have a means to take care of postpartum women or stabilize them to get them to a safe area. Creating birth-friendly hospitals, we know that's true. Expanding VA maternity care. I drive that in again because a lot of people leave the military and they don't get their benefits. But the reality is if they're still, if they get pregnant and they've been in the military for 2 years or more, they actually have access to the VA medical system and stuff. And then the last one, which is the one that doesn't belong, and that's that the Maternal Mortality Review Committee, the findings are open to the public. And the key is they'll be released to the public, but the key is that those committee discussions and everything are supposed to be in-house, because a lot of times it's not crystal clear at what caused the death. Basically, what I'll do is just stop right there for 1 second, and I'm gonna give just a 30, 60-second stop. Can everybody hear me, number one? And can everybody see me okay?
Yes.
Okay, gotcha and stuff. Are there any burning questions that you have just after that introduction that we can think of that I need to address before we move forward? Cool. And there probably shouldn't be. But I just wanted to make sure that we stopped after going about 10 minutes so that to do that. All right. I'm working with a clock right here, guys, trying to be on point. Okay. What we're going to do is just go straight into our number sessions. And one of the things that you are going to be in a position of is that you're going to actually have to be able to do an elevator discussion where you talk with people over about a 3 or 4 minute period and be able to convince community leaders, convince people in your church, people in your city council. You're going to have to be able to explain to them why is this urgent for you? So I'm going to simplify things and give you a couple of numbers that can make it plain. Number one, but one of the things we got to remember before we talk numbers, let's talk about what we're talking about. So we're talking apples and apples. There are two terms that we want to focus in on: maternal mortality rate. That's the number of deaths per 100,000. So kind of like what happened to Judge Hatchett's daughter-in-law. That was a maternal death. She had a child and she died within a couple of months and stuff of having a week or a couple of months period of having that child. That's considered a death. There's another phrase, severe maternal morbidity. Morbidity means illness. What you have to understand is for every single death, there's a certain number of sisters that get severely ill, so ill that they either have to get transfusions, stay admitted to the hospital, it costs them extra money, or they end up having a chronic injury or debilitating or some type of injury from just having a child. That's called severe maternal morbidity. Okay, so in the classic example of that would be Serena Williams. Serena Williams didn't die, but she had to stay in the hospital. She had to take blood thinners. All of that extended her care and everything, and it was a near miss where she almost passed away. Okay, um, why do we need these types terms? Well, this map right here kind of shows the morbidity and mortality rate for different per 100,000 births from all over America, and you can see that it's not uniform. You can see that you may have very low rates when you go to Maine. You'll have higher rates when you go to New Mexico and parts of California. The Peach section, Georgia, where I'm from and stuff, that they're kind of like towards the higher end of issues. So for every 100,000 women that are having a child, it varies from state to state. And that's one of the reasons why you had to have the federal government come in and figure a way to do, at least let's get the data right for what we're talking about and for the risk. But let's talk about numbers. The first number is a big number, it's just 2. All right. And in reality, I say 2, but the reason why Black maternal health and Black maternal health caught fire as a public health issue was a couple of years, about 3 or 4 years ago. They basically identified that in the last 20 years, the incidence for death for mothers in America had actually doubled. So that's why we use 2 as our first number. So that's across the board. Doesn't matter what your color is or anything like that. The incidence for maternal death in America has doubled. The sad part is, during that same 20-year period, in the rest of the world, the incidence of death for mothers decreased by 40%. So while the rest of the world is getting better, America's numbers are getting worse and worse and worse. So America was actually identified as one of 8 countries by the World Health Organization where the care for mothers was going in the wrong direction. And so all of that data that they were gathering, that was used by Kamala Harris, and it was used in order to help make these changes for maternal. And actually, I say Kamala Harris, the first funding for the maternal mortality conference that actually came under Trump in 2018. So everybody automatically assumes that the new administration is going to come in and just wipe out. Well, actually, Kamala and Biden were building on things that Trump actually put in place. So the key is, there's a good chance that Trump's going to look at these numbers that are being gathered, and they may decide to just keep the momentum going. So before you just assume that your funding is going to be cut off, that things are going to go bad, that things are going to get worse, in this, you got to remember, this is affecting all mothers, not just Black mothers or Hispanic mothers. It's all mothers. The rate is doubled. So the first number is 2. Let's go to the next. And this kind of shows you what I'm talking about in terms of that maternal mortality in the U.S. You can see the U.S. up top. In this one, it says it has about maybe 23 deaths per 100,000. If you look at New Zealand, it's 10% of what's happening in the U.S. This issue has actually been addressed in some countries that put having women and children as a priority. But if I were to ask you a question, true or false, the problem of maternal death, problems of maternal deaths in America can be decreased by 90%. True or false? The answer, of course, is true, because I showed you that in other industrialized countries around the world, they're already doing it. In America, we have this complex history that's kind of keeping us lagging. All right. Again, 90% difference between New Zealand and Norway and where the US is in terms of deaths for mothers. This is some of the data from 2018 to 2020. And what you see is it went in while the rest of the world's getting better from 2018 to 2020, the numbers in America got worse and worse and worse. And they're getting worse faster. So you ask the question, okay, well, if at this time, if the death rate for white women is about 13, it's now 20% now. Well, the death rate for Black women per 100,000 is probably about 60. Okay, but the percentages are about the same. So that ties us into the next number, and that's 3. Because so if women are dying in America at 2 times a high rate over the past 20 years, actually Black women are dying at 3 times the rate of how white women are dying. So the bottom line is, so when we talk about maternal deaths, these are what the numbers look like, and this is kind of like just kind of a racial breakdown, and the fact is that Black mothers, 55 out of 100 are going to be African American women. So 3 times. The second number that we focus on is 60%. And even though we focus on the 9 months that the women carry the child, it's 60% of the deaths occur after the child is out of the womb. And they happen in the OR, in the hospital, during the delivery process, within a week immediately after the process, and really up until about 6 weeks out from the process. So I consider that 6-week period kind of a danger zone. Okay. So if that 6-week period is a danger zone, after about 6 weeks, incidence of problems drops off to about 12% and stuff like that. So the key is, while everybody's focusing on the 9 months they're carrying the child, there has to be a reemphasis within all our organizations to focus on that 6 weeks that person's in the danger zone. And that's when you'll be able to save lives. The last statement is the thing that brought things home. When they started getting information from the maternal mortality review committees, the initial information that was coming in actually showed that up to 80% of the deaths that they were finding were preventable. So we have deaths occurring at a higher rate in America. They're 3 times the rate in Black women. 60% of the deaths occurring after the child is out, and then 80%. The other number is that 80% of these things are preventable, and the fact that that they are preventable, that's the thing that and avoidable. That's kind of like our little numbers take-home message. So when I ask you the question, if they say what percentage of maternal deaths are thought to be avoidable, most people say 66% to 80%. Okay. So 80% would be that proper answer stuff. Okay. Let's go into what I'll do is very quickly here you go. Let me back up just for a second. One of the things that happened, the way I got involved in the procedure was that I had a case where a patient nearly passed away. And I went to a OBGYN doctor who had 30 years experience in the field. And I asked her the question, if you had to save your daughter, what would you tell your daughter? If your daughter was the one who was having a child right now, how would you save your daughter's life? And she said, number one, I tell her she's pregnant 45 weeks, not 39 weeks. 39 with child, 6 weeks without. The second thing is, in the hospital, you're not going to be heard. So you need to learn to use the patient advocacy system. If you're not heard twice, then her suggestion is you need to get patient advocacy involved. Every hospital, in order to be JCO approved, has an office that's a patient advocacy office. That's there with professionals that are designed to make sure that that patient is being heard. Okay. And the reality is the system, all of these algorithms were put in place because the system really was having problems here in Black mothers. The third thing that she said was you got to make your 8 prenatal visits, and you need to have at least 4 prenatal visits, postnatal visits. But she also said that you got to take into consideration that there's a role for sexual assault, and if in women who've been sexually assaulted, they may be less approachable and won't run to get examinations on a regular basis. We try to use art to heal. This is our cover. We really preach this Hear Her campaign that I've already touched on before with the teaching symptoms. And all of the symptoms, again, they either deal with blood pressure, bleeding, blood clots, or infection. Okay. All we're doing is teaching the common person, and the CDC is doing is teaching the common person how to address that. Okay. We'll take a little 1 minute pause before I go into the next section. This is April Valentine. She passed away in California. Her husband is one of the main advocates for maternal health issues in the nation. She basically, with her husband, they had a game plan, they had a prenatal plan, a delivery plan, but they went into a hospital and her OBGYN doctor and midwife were not there. And the doula team that she had, they wouldn't allow her to come in, and they basically threw out her birthing plan. Ultimately, April ended up having major problems and bleeding out and passing away, and she's considered one of those situations where she's considered um, um, she's considered a maternal death, but fortunately, her husband's turned it into something positive. Okay. Ooh, let's take just 1 second. We're gonna take just a minute and a half and stuff. I'm gonna stand up and just stretch for a second. You guys can stretch, get a quick cup of coffee and stuff. If it's okay, I got my clock set. I'll be back in about a minute and a half. All right. Any questions we can think of, Mel, or anything like that?
When you come back, if you could just mention, how would you suggest that people escalate in the hospital if they're not being heard? So you educate about the symptoms, your doula team gets kicked out. What do you do?
What you have to do in that situation, you have to get that patient advocacy involved. Now, the reality is they're supposed to tell you if there's a conflict in the hospital. The hospitals are supposed to tell you and refer you to patient advocacy. But now when you go in there, you call patient advocacy, and it will be patient advocacy that has the trained people that'll come in and be the intercessor. If your doctor's not acting right, they get you a new doctor. If you feel like your doctor's not taking you into consideration and being respectful, they do that as well. The key is a lot of times we come in and we are not like comfortable enough to voice ourselves, voice what we're thinking. In the situation where you have the laboring mother, you have to have a team that can basically take up that slack. It's not the mother's responsibility. It's the father, whoever's there birthing with her. It's the big mama who's standing her hand. The reality is the doulas really do that. And doulas are trained professionals that teach women about their body changes when they're having babies. They go through the birthing process with the mother. And the reason doulas are so important is because the doulas serve as an advocate. They know the doula is a professional person who knows how to deal with patient advocacy and knows how to talk to the doctors. And even though they put the doula out at that time, if they were able to tie into patient advocacy, they would have been able to reestablish.
I think maybe Dr. Edmond, I'm not sure if you're still talking, if you went on break, but we can't hear you right now and your screen went dark.
Yeah, it's frozen at this time.
Yeah, I think you might be frozen, or I'm just seeing a blank screen.
I see him frozen.
Okay.
It's frozen.
Okay. Let's see. Not sure if you can hear us. You're still frozen. Actually, it looks like he might have dropped off. Sure, he's probably fixing it. Any reactions to what you've heard so far until he comes back? Is this news to anybody? Do you find the stats and how he's been moving through it helpful?
This is Barbara from DC. I find all this is very interesting. I had no idea that this was a big problem. So thank you for bringing that up. I didn't know that we were still being treated less than an average patient and we weren't getting the proper care when we needed it. But thanks for enlightening me. Thank you.
Yeah, this is Pastor Crawford, and I'm also echoing the same sentiments that this information need to be more available to our members of our congregations. I have been listening today, and my heart has been bleeding to hear this number and the stats, especially among our women of our color. So again, thank you so much for sharing this, Dr. Clark, and I pray that we can have more of this available to our entire membership, because they need to be informed of this situation.
This is Minister Stephanie Booker from House of Lords in New York, and I am very thankful that United Way offered us the doula program, where we learned a lot about this information that is being given to us today, and I continue to follow up on it. So I'm glad that this is a topic that we are addressing in our in the health work that we are doing in the community, because it's extremely important. So I would urge that if that opportunity comes back around again for anyone to be involved in the doula program, even if you don't become a doula, the information that you get is going to be really great.
Thank you. Thank you all. I still don't see Dr. Edmond back. So let me just say a couple things. Look, I work in health equity and health disparities, and every time I constantly have to renew myself, because otherwise I would stay angry and not effective. And so I hear you, and I definitely feel you. And we've talked about self-care, because we don't want the emotions to immobilize us. And that's one of the reasons why I asked that question towards the end, in terms of how can you advocate for yourself effectively. There's patient advocacy. There's also going up the chain to the charge nurse, to the chief nursing officer, to the attending physician, or to the chief medical officer. If you're in the hospital and you are not getting the care that you feel that you should be receiving, or you're just not being heard. I think it's really important to know what your options are. The other thing I would say, I can't remember if he said it, maybe he did, and we just heard about the doula option. Medicaid, which is, you qualify for that coverage that comes from the state, augmented by federal dollars. You qualify for that based upon income. Medicaid covers, depending on the state, anywhere from 40 to 60% of all births nationwide. So when he says that, Medicaid has extended from just covering the first 8 weeks after birth to now a year after birth, you can automatically qualify for Medicaid if, based on income for 12 months after you've delivered. That's huge. The other huge thing is many Medicaid health plans are now, or many states, Medicaids are requiring the Medicaid health plans in their state to cover doulas. And that's really important. So what Minister Stephanie just mentioned about the doula training, those people who are becoming doulas now have a mechanism to get paid to help the people who need the help the most, those individuals who are on Medicaid, who might not feel that they have a voice, who have social determinants of health that are working against them, that will potentially complicate their pregnancies. There is now a mechanism in many states for those individuals to get paid. And then finally, I always like to talk about, it is definitely bias in the healthcare system and Black women and their families not being heard. But there are also other pieces, like I mentioned, the social determinants of health, which I think Dr. Edmond is going to get to if hopefully he comes back.
I'm back.
Are you back? Wonderful. Okay. So it's just to finish up, it's just a mixture. It is a combination of bias in the healthcare system, bias in society, and social determinants of health, which we've talked about, that are making these statistics as bad as they are. So I'll turn it back over to Dr. Edmond.
Sounds like a plan and stuff. Do I need to go back to share or just click on my thing? Can you see it?
Not yet. We just see you.
Okay.
I think you have to reshare.
I got to reshare. Okay, hold on 1 second. Let me escape. Okay.
And I love while you're doing that, I love the blue background.
Try to work it out.
The symbols, it's beautiful.
So I go share. Okay, and are you guys seeing that for me and stuff?
Yes.
Right?
Yep.
And so let's see. Let's start slideshow.
So hopefully I didn't jump the gun, but
Oh,
you
okay.
know,
Is what happens is this, everybody, in learning and teaching, we try and come from different angles, and you have to hear it from different people and stuff, in order for you to get it. So you're 100% on point, the way you described. And now all that's going to happen is I get to reinforce what you mentioned. Okay, Mel. And the key is we use questions, we use other things just to reinforce that. So let's go ahead. Let's go into some of these causes and stuff like that. Okay, we've already talked about Black maternal deaths by the numbers and stuff. And if it caused urgency, and it's designed to cause urgency. But let's talk about what are the causes. When we think about causes, we have individual causes specific to people. We have relationships, how that person interacts with the world, community components, and we have societal issues that can play a role in terms of this. When we're talking about individual, everybody talks about Black maternal deaths. But let's be clear about how Black mothers are dying. Okay, if you look, when we talk about preeclampsia, that's basically uncontrolled hypertension. And when mothers get pregnant, once they get past about the 33rd week of pregnancy, the placenta is big enough to start producing this hormone that can cause high blood pressure. If that high blood pressure is unchecked, the mother can have strokes, and they can go into kidney failure and liver failure. Okay, so that's the dark blue. But there's another section that is that's kind of important with the Black women, and that is the green section. Black women have of all the women who have problems surrounding pregnancy, Black women are at increased risk for heart failure. And that's one of the things. So when we talking about taking care of African American women, we have to be attuned to some of the symptoms of heart failure. Most of those symptoms that were on that Hear Her campaign, some of them actually deal with like breathing issues that tie into heart failure. Okay, so but that's the difference in terms of things that are killing Black mothers. A heart failure is one of the issues that kill Black mothers at a high rate. Other things that kill them, you can have bleeding, bleeding surrounding delivery. You can have clots or embolism, clots that form blood clots, or you have fluid that surrounds the baby. That fluid can get into the venous systems, into the veins, and can cause clots to form that can cause deaths. But when we talk about hypertensive syndromes, what they say preeclampsia, the reality is it's basically, again, I mentioned uncontrolled hypertension and stuff. But when you get that hypertension, and that's really bad, it can actually affect your liver, and your liver can stop working well and can form toxemia, where the patient can basically goes into almost a type of a liver failure, where they stop producing platelets and different things that cause blood clotting in the blood. The liver stops functioning well and stops producing that. The worst situation is called HELP syndrome. And if the blood pressure gets so out of whack and stays so out of balance that you go into this liver failure, your liver can start to fail. You start to bleed because of red blood cell breakdown, but also you have these low platelets. If a person develops this syndrome, it's 25% fatal. Okay. So what you're going to, so the reason why we check those blood pressures so frequently in those last months of pregnancy is if we see somebody developing uncontrolled high blood pressure, that could be that will be letting us know, hey, this is a person who's at risk to develop this HELP syndrome. If a person goes into HELP syndrome, like I said, 25% of the time, 1 out of 4 of them is going to die and not make it out of the hospital. When we talk about high blood pressure risk factors, the risk factors, I listed them there. But one of the things on the moderate risk factors, if you go down to number 4, it says African-American race. What you have to understand is they talk about low socioeconomic level, age greater than 35 years old, and obesity. All of those things are risk factors for having high blood pressure or blood pressure issues. If you have chronic high blood pressure or type 1 or type 2 diabetes, or have autoimmune disease, or renal disease, all of those are high risk factors for hypertensive problems during pregnancy. Now, so those are some individual things. You know, how do you have pre-existing hypertension? What is, we said individual issues play a role in terms of the causes of this. One of the causes that I want to mention and introduce you to is called weathering. It's by Dr. Geronimus. Weathering basically says, and this researcher has shown that Black mothers, because of their exposure to chronic stress levels in society, they age prematurely. And by aging prematurely, that increases their risk during pregnancy. This lady looked at 300,000 births, and it tried to identify when was the best time that a Black woman should have a child. The best time was actually in her teens. Well, that was information back in the 80s and 90s, and people were trying to say, are you trying to tell Black women to promote teenage pregnancy? She was not promoting teenage pregnancy. What she was asking the question, why isn't the best time for them to have a child at 25 like it is 23, 24, 25 like it is for the rest of the American society? And what she basically was able to identify over the coming decades was that there's this weathering effect that can add up to 7 years of aging to Black women. And it doesn't just happen with Black women. It happens in European cultures. If you have a marginalized group of women who are subject to chronic stress, it develops in them as well. So what we believe is the chronic stress not being part of the mainstream in America is actually playing a role in affecting the DNA of Black women. So what does that mean? That means that a woman who's 25 25 will labor like she's 32. That also means that a woman who is 35 may labor and carry a child like they're 42. Okay, so this weathering component is a real entity, and so that's an individual component, because different people are subject to different wear and tear on their bodies before they get pregnant. So again, it's caused by constant stress. People believe racism plays a role. It causes premature biological aging. I said it adds up to 30 to 7 years onto your age. And this slide right here is taken from the Surgeon General's. And because that weathering is a real entity, what you end up seeing is if the death rate for Black women, if you follow the yellow curve, if you go right about here at the age of 35 to 39, what you actually notice is if in America the average death rate is 20 per 100,000, it goes up to 180 per thousand, almost 10 times increased death if you're over the age of 40 having a child. So what we have to get our families to understand is that if a mother had a child at 25 and 30, and then they end up having another child at 35 or 37, or there's a difference in her body. There's a difference in her risk. That mother needs more of a support system when she's having that third and fourth child, or that second or third child when she's older than she does when she's young. Okay, her risk for outcomes are 10 times worse if she has a child at the age over the age of 40. Okay, and there's unreleased data by I think it's Dr. Fatima out of Atlanta, and what she basically was able to show, she does work in Sierra Leone. She was actually able to show that a Black woman having a child in America over the age of 40 has the same incidence of death as a 20-year-old woman, 25-year-old woman having a child in the country of Sierra Leone, where they only have about 3 OBGYNs in the entire country. Okay. So the next thing, the Surgeon General is moving this way. All of the studies and the new information coming out is starting to show us, hey, a lot of the bad outcomes are coming from our more elderly mothers. So we have to put, so when we start talking about when we, where we, you apply your resources, the older that mother is, the more resources they're going to need. There are also some relationship contributors. You know, you got individual components, but how does that person relate to her healthcare system? Are they being heard by the system? They may have resources, but not be familiar with the system. Or just like I mentioned earlier in the talk, they may be a vet, but not really know that they even have access to the entire VA system to support them during this period. Also, people taking into consideration the relationships in terms of prior experiences. They may have engaged with the healthcare system and had a very bad outcome and stuff. And so they're not excited about, or they don't know how to navigate that healthcare system. So those are some of the relationships that can cause worse outcomes. But the reality is if you want to know kind of like some information that just came out like really like late last year, it had to deal with how you deal with treating bleeding women surrounding pregnancy. When do you decide to give a transfusion to a mother who's bleeding? For some reason, the American group of OBGYN doctors, they were using data that came from the 1990s. And in 1990s, basically, a guy looked at all women and looked at what their hematocrit was, then their basic baseline red blood cell count. Well, he found out that the baseline red blood cell count for Black women was lower. So he basically did a race-based kind of like decision to say, well, Black women don't need red blood cells as early as white women. So what we're going to do is they accepted the recommendation to delay giving transfusions to Black mothers. With Kamala Harris, they basically came in and they started doing race-based reviews of protocols. And they were able to identify that this one change in terms of how you address bleeding mothers, they're doing the studies right now. They believe it's going to have a major effect in terms of improving Black mothers' outcomes. So you ask the question, how do you get to a point where you transfuse a white woman before you transfuse a Black woman? Well, it has to deal with the race-based type research that was going on by the researchers. And but they corrected this. But once they corrected this and found this, they started doing studies. Now they're looking at pain treatment for mothers during pregnancy, for anesthesia and stuff like that. Pain treatment for kids all over. So remember, the people who are doing the research, you know, they have their backgrounds and they have their preferences as well, and they have their blind spots. But this is one that they believe that a treatment of an anemia surrounding pregnancy is going to have a major impact on decreasing the number of mothers that pass away. Okay. We talked about individual components, relationship components, and then you have your community and your neighborhood. But one of the things that Dr. Mel mentioned was the social determinants of maternal and infant death. And the key is, I'm not going to give you this whole line because I have a simplified way of remembering, of thinking about it. These are non-medical components, factors that play a role in terms of your outcome, in terms of your health. Okay. Food stability, education stuff. But the way I try to remember it is by asking a simple question. And that is, what did Joseph and Mary need when they had baby Jesus? Okay. We all know Joseph and Mary, in baby Jesus, he was born in a manger. Okay. So when we look at that, let's ask that simple question. Did baby Jesus have stable housing? No, he didn't, because baby Jesus was born in a manger. Well, did baby Jesus have a safe, loving environment? No. Baby Jesus had his mom and daddy, but remember, they had to go to Bethlehem for a census. So their entire network wasn't around them. They didn't have their family network around them. So you ask the next question, well, hold on, violence and threat, and was he born into a threatening environment? Was he born into a violent environment? And the reality is yes. Because remember the three wise men? When they came, they talked to Pontius Pilate, and Pontius Pilate, he said, hey, I mean, they talked to, I think it was Herod, and they said, hey, Herod said, let me know where the baby's born so I can come praise him. Well, when the three wise men didn't come back, he killed every young man under the age of 2. Jesus Christ was born under threat. Okay, he in unstable housing, didn't have a network surrounding him. And those are the things that, so when you talk about what social determinants are, ask the question, what did baby Jesus need?
What information do we take within our communities and within our churches concerning weathering? Is there something that you guys can give us so that maybe we can have some experts come out and talk, do some town halls or some?
Absolutely. Absolutely. Number one, I refer you to the Professor Geronimos, okay, and the person who wrote the book, and the key is, in the book, she also gives suggestions on how to address weathering and stuff. And so I want you to almost imagine that, and part of addressing weathering is getting a better understanding of it. She can come talk to you. She has that book that I refer to as a great book, an introduction to it. And there are also some articles. But the key is, let me tell you, for when you're 100% right that women are waiting and
Dr. Edmond, I think you got booted off again. I would agree with him. Definitely that book. I would also, mention, I always talk about the 5 self-health actions: nutrition, hydration, sleep, movement, and most importantly, managing the stressors in our life, because that is the counterpoint to weathering, especially addressing the stressors in our life and having a strong self-image and rooting in a practice, a spiritual practice, a mental health practice, an emotional health practice that renews us every day and protects us against the toxic effects of stress in our life. The other 4 self-health actions definitely do that, but I say managing the stressors in our life is number 1. So to the extent that your church is engaged in helping people manage stress through your ministry or various ministries, I think that's a huge community resource. When I mentioned self-image and having a strong self-image as a Black person in America, there was a study that was done that showed that Black men who internalized the messages that we receive from society about our self-worth, vis-a-vis racism, and internalized that, they had more DNA damage and evidence of aging than those Black men who had a strong self-image. They did not show those same effects of aging. So that self-image and the managing stressors, along with the other 4 self-health actions, I think are our most powerful ways to manage this concept of weathering. But as Dr. Edmond said, I also too encourage you to read the book and read Dr. Geronimous's suggestions as well.
got you.
I'm just filling in time.
Oh, hold on. Let me undo my mute, and then I'll be
Okay.
straight.
Yeah, we can hear you.
Okay, you can hear me? Okay, great. So the bottom line is so that's really kind of like, very quickly, Mel, your answer was 100% on point. But what I'm doing is basically, so this is for my nieces and people in my family. And also, believe it or not, if you're active duty military, they will save your eggs for minimal cost. Okay. And a lot of Black women who are getting hip. A lot of our Caucasian sisters are already hip to that. But in the military, a lot of our African American sisters don't understand that the federal government will pay for that. Okay. So the deal is, but at the age of 36, that's when your egg production drops off. So if you get your eggs squared away and put on ice at the age of 33, then you can take your time to go after it. But once again, when you're over the age of 40, you can have it's a higher risk component. But the reality is our goal is to basically, as they find out more and more about this, as I teach you more and more about the support systems, the social determinants of health, if you take care of those entities and you take care of those factors surrounding the woman's pregnancy, you can decrease those, you'll be able to decrease those incidents of problems. Okay. And but basically I told you on social determinants of health, I said, the first maybe 4 of those can be taken up by asking the question, what did Mary and Joseph need for baby Jesus? The other ones can be taken care of by looking at what the 3 wise men brought. And they brought gold, frankincense, and myrrh. And if you look at frankincense, it's like you can burn it. It gives a sense of well-being, calmness in the home, but you can also use frankincense for pharmaceutical purposes as well. When you look at myrrh is it's an antiseptic. You can use it to clean wounds. It's a pain medicine too. And if you remember when Jesus was on the cross, my understanding is that somebody came up and offered Jesus some wine with some bitter drink. That bitter component was myrrh. It was a pain medicine, okay, that they were trying to offer Jesus Christ. But myrrh was the most expensive pain treatment pharmaceutical around at that time. So what that wise man was bringing was good health, okay? And so but they use myrrh for gastric colds, GI issues, antiseptics, multiple purposes. So what that guy was bringing was a sense of those 3 wise men were bringing, a sense of well-being and calm in the home, a home without violence, a home without threat, health, access to quality health care, access to and the ability to access to quality health care. And then the other thing that the wise men brought was gold. Now, what did that gold allow them to do? It allowed them to actually, it brought safety to the household. They were able to leave Bethlehem, go all the way to Egypt, reestablish another home. They were able to travel in the home, get Jesus educated. The reality is those are the social determinants of health. The question is, what did Mary and Joseph need? And then what those 3 wise men do. So what the 3 wise men, the gifts were doing, were actually providing for the social determinants of health. They were giving Jesus everything that family needed to offset the social determinants of health that could have adversely affected his birth. And so that's how I remember those. The only thing that it didn't mention that is incarceration, and that's a social determinant of health. But just as sure as we have, so when we talk about causes, we have some of these causes that are social causes, individual causes, relationship causes, and then the social determinants of health. But the thing that I'm happy to talk to you guys about are the spiritual causes of Black mothers' death. What you have to understand is mental health disease is one of the major factors that causes injury and deaths to mothers. And 80% of mothers in America are going to have the blues. And during the postpartum period, 20% of the mothers are going to have to go on some type of pharmacotherapy in order to get them over those blues. The other spiritual death that I mentioned is homicide. No matter what we talk about, we'll talk about bleeding during pregnancy. We'll talk about blood clots. We'll talk about heart failure. What you got to understand is if you take the 3 leading causes, high blood pressure, bleeding, and pulmonary embolism, if you add all 3 of those together, they're not gonna overcome the number of women who are killed due to violence surrounding pregnancy at some point during their whether it's when they're pregnant or after, during the postpartum period. And the problem with that number is that during the homicides, over 60% of those homicides are committed with a handgun. So the key is we may be actually seeing the effects of our gun approach to guns impacting the livelihood of mothers in America. All right. So again, we talk all the medical stuff. When we get past the medical stuff, it's the spiritual things, it's the homicides and the violence that kills women at a larger rate, at a higher rate than anything else. I can get you down. We're getting down to those other things, but having a gun in the home, and not having safety in the home are some of the major things that cause death for women in America. So again, we look at those social determinants: food stability, education, income, neighborhood demographics. Remember, when Joseph moved to Egypt, he probably put him in a good neighborhood and everything. Safety, housing, access to care, rates of incarceration. So if I ask you the question, true or false, social determinants of health include food stability, income, access to health care, safety, and housing. The answer to that is true. All right. But I say that, but when we talk about those things, there's a trend going on in our community right now where they're basically, in order to address these social determinants of health, we have some women that are moving back to live with their mothers and fathers so that they can be part of a community and fall under the health and under the social umbrella of their parents. This isn't nothing new, because although it sounds kind of like simplified, the key is some young women are choosing to have their child when they have the support system of their mother and father, so they go back to their community. In other situations where they do not have that, where they don't have a family with them, people are actually monetizing supplying the social determinants of health. There's a new hotel that's opened up in Virginia that specifically caters to women who've just had children. They bring them in the hotel. They have people who help with the baby. They give the mother massage, good nutrition, and a good night's sleep. The whole goal is to have the mother come in there and spend a week there so that she can get used to herself and get used to her child. But it costs thousands and thousands of dollars to do. So all they're doing is addressing the social determinants of health at that hotel, but you're paying actually a physical fee to get them taken care of. So basically, one of the things that is also a cause is poor access to care because of insurance deserts. Remember, all states haven't taken the Obama Affordable Care Act. And the other issue is you may live in Baltimore right across from Johns Hopkins, but if you don't have insurance to walk through the door, then that healthcare is not going to do you any good. But that ties us also into this whole concept of maternity care deserts. And this is something that I really want the churches to understand, because a maternity care desert means it takes more than 45 minutes or an hour to get to quality OBGYN care. In America, the places that have the highest incidence of death are rural spaces. So the rural parts of Georgia, the rural parts of Illinois, and in a lot of those states, and you remember, it's not just Black women that are passing away. It's all women that don't have access to proper maternal care. You can be in Southwest Atlanta, but if you can't get to North Side or Piedmont, where they're delivering most of the babies there, you're technically, because of traffic, you're technically in a maternal desert. So the key is, when we talk about these maternity deserts, they do play a role, but that ties us into this concept of workforce changes. And they're really just, I'm going to introduce you to 4 people. You got the physicians, you got the nurses, labor and delivery nurses who take care of the patients and help them during the delivery process. You have midwives. Now, midwives are basically trained nurses who are trained in how to deliver babies, okay? And then you have doulas. Doulas are basically skilled women who are skilled advocates who help and assist mothers to have the child. They're with them at every phase of the delivery. but they're also advocates for the mothers, and they're trained to recognize mothers who are in distress. And Mel, you mentioned it already. Louisiana and a lot of different states know Medicaid is paying for them and stuff. And doulas have been shown to basically improve the outcome for mothers. But very quickly, as we talk workforce changes, I'd be wrong if I didn't tell you, mention this thing called the Flexner Report. Basically, in 1910, a report was prepared by this guy named Flexner. I think it was Carnegie, the millionaire, was trying to decide which hospitals and which medical systems to support with his money. He had this guy Flexner visit like 155 different places that were training doctors, nurses, and the healthcare workforce in America at the time. And what he did was basically he wrote up a report that compared their care to Johns Hopkins in Baltimore. And if you didn't compare with Johns Hopkins in some way, then they made the recommendation that they would not finance your medical school or nursing school, whatever. And then what they'd also do is they basically redirect monies from the state and everything away from your institution. So effectively, they closed down institutions. Before the Flexner Report, there were 155 different medical schools. After the Flexner Report, there were only 85. Now, there were probably about 8 Black medical schools in 1910. After Flexner Report, there was only 2, Meharry and Howard. So what we're actually dealing with is 110 years of graduating classes in doctors from 6 Black medical schools that are not in existence. And so, and a lot of people say, okay, hey, well, you're always talking about Black issues. Let me tell you what happened to the women's schools. There were 7 women's schools in 1910. After the Flexner Report, all 7 women's schools got closed. So I want you to imagine that you had 110 years worth of 7 medical school college worths of graduating classes, women that are in the market. Women would be in control of birthing birthing children in America and stuff. And so that's so after the Flexner Report, the gatekeeper for delivering children in America was a white male with 2 years of college education who was on staff. And if you remember, back in the 1940s and 50s, believe it or not, if you were in rural America, if you were in the country, 75% of the time you were delivered by a midwife. Okay. After the Flexner Report, they began saying, hey, you know, midwives are not as safe and not as clean as having a baby in the hospital. So what they did with these states was start moving from having babies in the community to moving to having babies at hospitals. But there was one thing they didn't tell you about the hospitals.
Just a quick story about what he's saying about the Flexner Report. My grandfather was a rural physician in the early 1900s in North Carolina, a little town called Franklinton, right outside of Raleigh. He was at one of the medical schools originally that got shut down, and he had to transfer in his last year, which I think was 1916, to Meharry, thankfully, which was not shut down, so that he could finish his training and then go on to World War I, and then ultimately move back to his community in Franklinton to take care of actually all patients in the community. But that Flexner Report, 50,000 probably more Black physicians would exist today at minimum if those medical schools had not been shut down. Yet another way that we've been hampered in terms of being able to best advance in America in terms of our health and well-being and closing health disparities.
Am I back, Mel?
Yes. Okay, Rand.
Okay, got you. So Mel,
I'm just doing filler.
You're 100% on point. So the key is, what we have to understand is that this whole the effect of racism and stuff has actually had a major impact on where we are today. And so that's why the American Medical Association actually issued an apology to the National Medical Association and to the Black community because of the decision that happened from the Flexner report. Okay. So other than that, as a result of that, in America, we're flipped. Every place else in the world that has a very, very low incidence of death for mothers, the primary caregiver is a midwife. So if I go to Finland, and when we look at Finland, they do have OBGYN doctors, but if you're a young, healthy woman having a child in Finland, the people who will be coordinating the delivery of your child you'll have a nurse practitioner, and you will have, the day you deliver, you'll deliver with 2 midwives. Now, if you run into problems, there'll be an OBGYN doctor that they can refer to. But what you have to understand is because of what they did by making the white male the gatekeeper for delivering children in America, if you go down and look at America, America's backwards. Most of the children in America are delivered by by doctors. So it's the workforce issue. We do not have enough midwives functioning in America. Okay. So they're just now training up generations of midwives to help take care of this issue. And the reason it's like that is because there was a conscious decision made to make the white male the gatekeeper. But I mentioned earlier that there was a time when the gatekeeper was actually the Black midwife, and that was during slavery. Because during slavery, remember, every child born added money to the master. So the best people to deliver children were actually Black women, the ones who had the most education, the most training, the most skill. And that, I'll tell you a little bit about how that ties into our book. So if you want to, there was a workforce imbalance between midwives and OBGYN doctors. And until we fix that, you're never going to be able to fix the whole problem. But as a church member, you're going to be able to do some things. But that's where we get maternity care deserts from. All right. This is your density of midwives. And you can see down in here, you don't have quite as, it varies from state to state. But until we address that midwife issue, we're not going to be where we need to go. But we can have people come in who can move the dial, and that's doulas. And those doulas are the advocates for mothers when they're pregnant. Okay. Those are the people who understand those signs of a mother having problems, and who can basically, and the data and the literature basically shows they're professionals. They're trained for continuous physical, emotional, and informational support. So in most of the best countries, you actually have doulas that do the lion's share of education on delivering children, on how it is to be a mother and deliver a child. So when you look at Finland and you look at these other places, you have the midwives working with nurse practitioners, and the doulas do most of the education. Okay. And so, and then the doulas are engaged in helping to take care of that mother as a team. But the reality is everybody wants data. This is true. The effects of doulas and their outcomes, you have an improved outcome if you have a doula involved. You say, and I may have been ahead of the curve. My son's 22 years old, but when I had my son, I got a doula. Absolutely. I was having my son up in Maryland. I didn't have a lot of family support, but no, I hired a doula to come in there and make sure that everything went right for my wife, And I won't belabor this and stuff because I've already talked about it. But the reality is in a lot of our families, we have doulas too. They just don't call them doulas. They call them big mamas. In Ghana, whenever somebody gets pregnant, before they have a child, a cousin comes and lives with them for 6 weeks. Okay. And then the other thing is so that's really what happens. You have communities that get together that can basically become advocates for the mothers and stuff. Okay. We have labor and delivery nurses. I won't belabor those, but the bottom line is that ties us into the question: which of the following healthcare providers directly deliver or catch babies? Okay. Is it doulas? Nope. They're there. They're advocating for the mother, but they're not actually pulling that baby out of the mother. Midwives? Yes. And remember, I told you 75% of and back in the 1940s and 50s, 75% of the people delivered. If you weren't in a big city, it was by a midwife. Obstetricians? Yes. And then labor and delivery nurses. No, the delivery nurses do not deliver the child, but they assist and they help. So that ties into our learning objectives. That means we've done by the numbers. We talked about the causes and stuff. And what I'm going to do very quickly is introduce you to a mother's health support. I've been referring to it constantly, over the course of the day. This is Dr. Fatu Forma's an article from the New England Journal of Medicine in 2023. And basically, she basically got all the components of a state-of-the-art, support group to improve outcomes. Now, between me and you, all they had to do was really look at what was happening in Finland and New Zealand and copy what they were doing. Evidence-based care. At the top of the screen, when we say evidence-based care right here, what happens is that means we use algorithms. We have evidence on what's the best way to do fluid resuscitation and blood resuscitation for mothers. We have the best way on what medicines to treat a mother who comes into the emergency room or an urgent care that has high blood pressure. Those are being standardized right now. They basically, as a physician at Hopkins, I have to undergo training once a year to review what the standards are in terms of how to treat mothers with high blood pressure or mothers who are bleeding and stuff. Let's look at access to quality care, telecom and telehealth and remote monitoring. That with COVID, that's one of the things that's coming that we're doing Zoom talks right now with COVID. That's one of the things that they're using and they're extending to make sure that mother can get access to the care provider and stuff. Psychosocial support. That's that mental health component and stuff. We talk about paid maternity and family leave. That's one of the things that's a big giant difference in some of these European countries that have the low incidence of death. We act like it's something special to have the mother go out on maternity leave. If it was 10 years ago, people would be laughing at me and say, what do you mean maternity leave? The bottom line is now we're sending the mothers out, we're sending the fathers out. We think we're doing a good job by giving them 4 to 6 weeks off. In the UK, you get about 30 weeks of paid vacation. I think and the father gets paid vacation too in order to have the child. In other words, the entire community is focused on having a quality child and supporting that mother and child. Socioeconomic support. We talked about Medicaid. One of the things we want to keep in mind, hey, they give extra money so mothers can buy food, and doctors can actually prescribe, quality food to get mothers money to go purchase decent vegetables and things to help during the prenatal period and stuff. When you talk about the inner circle, on the inner circle, you have the OBGYN doc. On the specialist on this, I am not seeing, it's kind of interesting. I don't see the midwife on here, but the midwife would be where the OBGYN doc is, okay? Well, here you go, a certified nurse midwife. So these are the two people who catch the babies. And all they're saying is we have to have a network where you can refer to different other experts and stuff. But see right here, doula and social support is critical and key. All right, I'm taking it home. Like I said, 90% of this thing has already been fixed. All you have to do is look at what they're doing down in Finland. If you want to get some ideas of what you can do in your local church or your local efforts, they did a comparison between the American system and the Finnish system. The Finnish system has one of the lowest incidence of death for mothers in the world. And a lot of people say, well, hold on, there's a difference in terms of the body and When they did the study, they basically were able to negate and rule out differences in body habitus and all that other stuff. Their take-home message was that it's actually the difference in the two medical systems that's resulting in the difference in the outcomes. So one thing they do as soon as you get pregnant in Finland, they give you a box that basically gives you enough materials to take care of your child for like a year. All right. They have, and so I'll just very quickly hit these. In the US, we have 20 deaths per 100K. For Black women, it's 60. In Finland, they have 2 to 3 per 100K. Our medical centers are the main places where we have kids.
Right.
Okay, so basically, once again, this problem is 90% able to be addressed. The main thing that over the last Mel, I want to thank you for letting me come here. The content that we have that you've already had, I think it puts you guys on the kind of the cutting edge, and it gives you an update and gives you everything you need. From my standpoint, I'll have some information on the book that I wrote. It's an educational book that's basically geared towards, teaching Black families, how to better take care of the mothers. And that's basically it. And we'll just close it out right there, Mel, and just say thank you. And I appreciate you. Sorry about my little technical stuff. I keep coming and going and stuff.
No, yeah, hey, it's
Cool.
it is part of the being virtual. But does
Yeah.
anybody have any last minute questions for Dr. Edmonds before we close out?
I have a question.
Yes, ma'am.
Dr. Edmonds, do you know what specifically Finland, or have an idea of what they put in those boxes? Because I was just thinking to myself that, okay, go ahead.
You're 100% right. Actually, sure. What I can do is I can give you the article, and they have a list. They modified the list. Finland started doing this in like 1947 for the poor people in Finland. The results on the patients were so good that they basically in the 1960s instituted for every single woman in the country that's having a child. Okay.
That's
And
amazing.
I think it's about 40 or 50 items and stuff that are targeted. The onesies, they have a place where the kid can sleep. They have stuff with bottles and stuff. It just almost like a utilitarian thing that allows a mother to just get started and have good quality, get started. So there's never questioning whether or not they got enough the equipment to take care of those mothers. And that's that box, and is what they call it. That box is one of those things that can be implemented for you. I don't have time to the question, but one of the things I was going to say is I was going to pose a question. Hey, what ongoing project do you have right now, whether it be feeding the homeless, whether it be transporting people to the doctors, what ongoing project does your church have right now that could be modified in order to address one of the social issues that need the social determinants of health? And so that box that you're doing, that's providing healthcare, it's providing needed resources to take care of that kid. And that's it's been mimicked around the world, and it's a known entity that helps with terms of outcomes. Any other questions, y'all guys?
I have a comment. Hi, this is Crystal Bradford from New York. I just wanted to say thank you so much for this presentation. And the last time you were with us, you shared an audio link to the Quilt Maker book. And I just wanted to say it was such a compelling, touching story. And just want to encourage everyone, if you didn't take the opportunity to listen to it, please, please take the opportunity, because it really was a wonderful story.
Gotcha. I hope it's a love story, but it's got some medicine in there. But the other thing is it's on sale, believe it or not, for if you go to audiobooks on iPhone and stuff, it may be $5.99 or something like that. And it might be $8.99 if you do it on Amazon. The reality is we give proceeds to the Black Women's Wellness Alliance. That's where the money for that goes, basically. And it's a labor of love. But if any of you guys need me to come speak at your church or anything like that, I'll be more than willing to do that and do book clubs or anything like that. But the main focus is, for the holidays, if you just spread the word about the quilt makers, and just the like I said, it's getting 5 stars in terms of a quality story, but it also ties into a lot of African American heritage and stuff as well. Any other questions, guys?
Yes, can you put the information in the chat so that those who want to get the book can get it, please?
Sure, we will try to do that. Chat.
Also, if we want you to come and speak at our church, is there any kind of process by which we can be in touch with you?
Sure. You guys can contact directly with me, and I have my handlers. What would it be? It would be I'll give you the name of the book. It's The Quilt Makers is one word. Quilt Makers. And it's the art of hearing a Black Mother's Cry. If you again, if Brandy's on, Brandy can I send you a copy of the PDF for the book so you can find out, give it a little texture and feel for exactly, you know, what it's about and everything. Okay. And I'll put
Actually,
my
Sarah could probably do that if you
thank you
don't
so much.
mind, Sarah.
You can do
Yeah.
that, we call it even and stuff. And just reach out to me and I'll take it, we'll take it from there in terms of get things set up. But it's like I said, it's a nice, compelling story. And we don't have to do this whole talk. We can focus more so on using art to heal, and we can tailor it to the audience in order to introduce people to things. And so thank you so very much for having me. And
All right.
you
Thank
call it
you.
even.
Yeah, thank
Right.
you so much, Dr. Edmond. Thank you, Health Navigators, for all the great questions. Again, Merry Christmas, Happy Holidays to everyone. And, you know, if I don't see you before, I'll definitely be seeing you in the new year.
Okay.
Yeah.
All right. God bless
Thank you,
you.
everyone.
Everyone.
Right.
Thank you,
Bye-bye.
Dr. Edmond. Thank you.
Bye-bye.